Hello, a very good morning to all of you. Am I audible to all of you? Please add in the box. Okay. So, let's start with the topic biochemical basis of fluid therapy and Donan's membrane equilibrium. Yes, you hear me? Please write in the box. Neha? Neha, Vikas, Mansi, Jyoti, Himanshu. Please write in the box. Am I audible? Am I visible to all of you? Okay. So, a very good morning to all of you. Today's topic is biochemical basis of fluid therapy and Donin membrane equilibrium. First topic, biochemical basis of fluid therapy, is from Unit 3rd, Veterinary Analytic Biochemistry, and another Donin membrane equilibrium. This topic has been taken from Unit 1st, that is General Veterinary Biochemistry. So, first we take biochemical basis of fluid therapy. Body fluids, you all know about body fluids. An adult animal contains about 60% fluid of its body weight. What is the most abundant constituent in the body? As you all know. Intracellular fluid, please add in the box. What is ICF? Please add in the box. What is ICF? Yes, intracellular fluid. Please add in the box. What is ICF? ICF consists of about 2/3 of total body fluid, and the extracellular fluid, that is ECF, which constitutes about 1/3 of the total body fluids. So it means almost 55 to 75% ICF and 25 to 45% ECF. Extracellular fluid, ECF, is divided into 3 subcompartments or spaces, like interstitial, that is extravascular, intravascular, that is plasma water, and lastly transcellular. The interstitial contains 3/4 of all the fluid in the extracellular space, means it is present in 3:1 ratio. The intravascular, means plasma water, contains the fluid, mostly plasma, that is within the blood vessels. Please remember, total blood volume is roughly 8% of body weight and plasma roughly 5% of body weight. So please remember, total blood volume is roughly 8% of body weight and plasma roughly 5% of body weight. So there are 2 types of fluids, body fluids. First is intracellular, second is extracellular fluid, ICF and ECF. ECF is further divided into interstitial, extravascular, intravascular plasma water, and transcellular. Fluid movement between the intravascular or interstitial spaces occurs across the capillary wall and is determined by various forces like capillary hydraulic pressure and you all know colloid osmotic pressure. The fluid in the transcellular compartment is produced by specialized cell responsible for cerebrospinal fluid, gastrointestinal fluid, bile, glandular secretions, respiratory secretions, and synovial fluids. Daily water intake is about 10% of the body weight and can vary from animal to animal with respect of their age, environment, feed intake, etc. So there are various factors which influence the daily water intake of an animal. Daily water loss equals daily intake, and this loss occurs through the skin, lung, kidney, and GI tract. So you can see here this intracellular fluid 65%, around 65%. plasma around 8%, interstitial fluid 25%, transcellular fluid 2%. So it means extracellular fluid almost 34%, and this 34 to 35%, and this is intracellular fluid, which is about 65%, means 2/3 and 1/3. Now it is clear to all of you the percentage of intracellular fluid and extracellular fluid and the ratio of interstitial fluids. Please write in the box. Is it clear to all of you? Here you can also see this is extracellular space, intravascular space between vessel walls, this is interstitial space, and this is intracellular. It means this is intracellular space and this is extracellular space where extracellular fluid is present. You can see here this intracellular, this interstitial space, intravascular space, RBC, and this RBC and this intravascular space or where plasma is present. This is extracellular space. Now, composition of intracellular and extracellular fluids compartment in, you can see milliosmol per liter water. This is extracellular, intravascular, and interstitial. This is intracellular. So, principal component of extracellular fluid is sodium, you all know, responsible for much of extracellular fluid osmolality, and principal component of intracellular fluid is potassium, key role in the maintenance of transmembrane potential, you all know. So you can see here this intracellular potassium is maximum 157, and in this extracellular you can see here sodium is present in highest concentration. So which is extracellular? Which is the most important extracellular cation? Yes, please write in the box. Yes, and in intracellular, which cation is mostly present? Please write in the box. Potassium. Okay. Principal component of extracellular fluid is sodium, and principal component of intracellular fluid is potassium. This is responsible for maintenance of transmembrane potential. So again, you can see through this picture, this ICF, calcium, magnesium, potassium, phosphate protein, and this ECF, extracellular fluid, sodium chloride, and this bicarbonate. So you can also see from this diagram, this ICF, highest potassium, and this in this ECF, highest sodium. So what is fluid therapy or types of fluid therapy? First is replacement therapy, therapy in which we infuse some fluid, some type of fluid which is lost from body. Second is adjunctive therapy or fluid resuscitation. One type of fluid is given to remove other type of fluid. For example, mannitol 25% is given in case of ascites and edema. And lastly, supportive therapy, fluid is given to animal just support to cure quickly, like amino acid, minerals, multivitamins, and some carbohydrate, etc. So patient needs fluid therapy or IV fluid therapy for maintenance to supply daily needs, replacement to replace deficit and ongoing losses, and lastly, resuscitation to correct an IV or extracellular deficit. What are the aims of fluid therapy? First is avoid dehydration, maintain an effective circulatory volume, prevent inadequate tissue perfusion during a period when the patient is unable to achieve goals through normal oral fluid intake. So please remember, prevent inadequate tissue perfusion during a period when the patient is unable to achieve goals through normal oral fluid intake. Intravenous fluids have a range of physiological effects and should be considered to be drugs with indications, drug range, dose ranges, cautions, and various side effects. So these are the aims of fluid therapy. What are the indications of fluid therapy? Fluids are administered to patient not only to replace fluid loss, but also to correct electrolyte abnormalities, promote kidney diuresis, and maintain the tissue or organ perfusion. Or we can say for rapid restoration of fluid and electrolytes in dehydration due to vomiting, diarrhea, shock, due to hemorrhage or sepsis. So it is indicated during shock, dehydration, diuresis, toxicities due to toxicities and renal diseases, burns, and after surgical procedures, that is to prevent hypotension, as hypotension may due to vasodilation, decreased cardiovascular function, etc. So it may be indicated in anaphylaxis, cardiac arrest, hypoxia, post GI tract surgeries, acid-base abnormalities and electrolyte abnormalities for maintenance, replacement of loss, or as a special fluid. So these are the indications of fluid therapy. First and foremost important indication is to correct or restore fluid and electrolytes balances or electrolytes in the condition of dehydration due to vomiting, diarrhea, shock due to hemorrhages or sepsis. Am I audible to all of you? Please add in the box. Please add in the box. Am I audible? Am I visible to all of you? Okay, good. What are the advantages of this fluid therapy? Provide the patient with life-sustaining fluids, electrolytes, and drugs, immediate and predictable therapeutic effects, preferred for administering fluids, electrolytes, and drugs in emergency situations, allows fluid intake when a patient has GI malabsorption, and permits accurate doses titration for analgesics and other drugs. So these are the advantages of fluid therapy. What are the disadvantages? Needs hospitalization, costly. They may create infection, pyrogenic reactions, discomfort, poor patient compliance, and it may cause fluid overload, or there may be chances of fluid overload. So these are the disadvantages. Dehydration. What is dehydration? Dehydration, or the loss of fluid from interstitial space in the form of increased fluid loss from vomiting, diarrhea, or polyuria, is one of the main cause of water reduction in body. So dehydration, or the loss of fluid from the interstitial space in the form of increased fluid loss from vomiting, diarrhea, or polyuria, is one of the main cause of water reduction in body. Signs include decreased skin tenting, sunken eyes, depressed mentation, and tracheal or dry mucous membranes. Capillary refill time. This is an important feature. Capillary refill time, CRT, 2 to 3 seconds in mild cases and greater than 3 seconds in severe cases, and slight depression of eyes into sockets. These are the signs or symptoms of dehydration. So, diagnosis of dehydration. We can diagnose dehydration by physical examination, by weight loss. You can see PCV increased in the case of dehydration. PCV means, what is PCV? Please add in the box. What is PCV? Please add in the box. What is PCV? What is PCV? Please add in the box. This is packed cell volume, or we can say hematocrit volume. Okay. Next is albumin or total protein increase in the case of dehydration, or blood urea nitrogen and creatinine. Maybe high or high in concentration in the case of dehydration. Blood urea nitrogen and creatinine. levels are high. Pre-renal azotemia. This is the condition when blood non-proteinous nitrogen levels are increased or level increases. Pre-renal azotemia. So by physical examination, by weight loss, obesity increased, albumin total protein may be increased, BUN and creatinine level may be high, or pre-renal azotemia is present in the case of dehydration, and we can diagnose by these means. Next is clinical examination of degree of dehydration, means these are the degree of dehydration and these are the clinical signs of dehydration. Less than 5% not clinically detectable, 5 to 6% septal loss of skin elasticity, then 6 to 8% obvious delay in return of tendon skin, slightly increased CRT, capillary refill time, eye possible sunken and dry mucous membrane, 10 to 12% severe skin remain tented, very prolonged CRT, sunken eyes, dry mucous membrane, possible sign of shock, tachycardia, cool extremities, rapid and weak pulse, and 12 to 15 more severe obvious sign of shock, and death may be occur. Death imminent. Next is shock. These are the clinical signs. This is hypovolemic or cardiogenic shock, and this is vasodilatory shock. You have already studied in the previous class. Have you studied in the previous class this topic shock? You have studied the topic shock in your previous class? Please add in the box. Have you studied? Please add in the box. Have you studied in the previous class? Okay. So this is hypovolemic and cardiogenic shock, and this is vasodilatory shock. Heart rate in the case of hypovolemic cardiogenic shock, tachycardia, rapid HR, heart rate and end stage severe bradycardia, pulse strength weak, and this in vasodilatory bonding, mucous membrane pale becoming white, and in the case of vasodilatory bright red, capillary fill time. This is an important feature. This is prolonged in hypovolemic or cardiogenic shock, and this is rapid in vasodilatory shock. Blood pressure may initially be normal due to sympathetic response, then decline, and in this vasodilatory shock, it is also low. Temperature cool, temperature of extremities in the case of hypovolemic and cardiogenic shock, and in the case of vasodilatory shock, it is warm or because of vasodilation. So type of IV fluids or fluids used in various fluid therapies. There are two types of fluids. First is crystalloid and another is colloids. Plasma expanders are the another name for this colloidal fluids. First is crystalloid and another is colloids. Crystalloids are again classified into three: isotonic, hypotonic and hypertonic. These are the examples of isotonic, hypotonic and hypertonic. Isotonic 0.9% sodium chloride, NS, lactate ringers lactate, you all know, and dextro 5% in water, D5W. These are isotonic in nature. 0.45% sodium chloride is hypotonic, and 5% dextrose in NS, 5% dextrose in lactate ringers, 5% dextrose in 0.45%, half NS, 10% dextrose in water. These are hypertonic in nature. Albumin, plasma proteins, fractions, dextrins, and HITA starch. HES, these are the colloids, or we can say plasma expanders. So, crystalloids and colloids, these are isotonic. Again, this is a classification of IV fluids, blood and products, and this is not blood IV fluids, again divided into crystalloids and colloids. We have already studied. Crystalloids includes glucose, crystalloids include glucose containing electrolyte solutions and various mixed solutions. And colloids again classified into proteinous and non-proteinous. Proteinous, gelatins, hemosyl, gelofuscin, and this albumin, 20% and 5%. And non-proteinous starch and dextrins, starch, HES, pentastarch, tetrastarch, and this is dextrins. So this is the classification of various fluids indicated in fluid therapy. Non-blood IV fluids, crystalloids and colloidals, colloids proteinous and non-proteinous, and this is proteins, gelatin, mucil, gelofuscin, albumin, and non-proteinous starch and dextrose. Again, starch includes HES, pentastarch, and tetrastarch. So, crystalloids. What are these crystalloids? Crystalloid are electrolyte solutions with the small molecular or molecules that can diffuse freely from intravascular to interstitial fluid compartments. So these are small molecules. These are electrolyte solution with small molecules that can diffuse freely from intravascular to interstitial fluid compartments. The principal component of crystalloid fluid is sodium chloride. Sodium is the principal determinant of extracellular volume, you know, and is distributed uniformly in the extracellular fluid. As we have just read that sodium is the principal determinant of extracellular fluid. Sodium cannot gain access into intracellular space, hence all sodium will remain in the extracellular space, thus expanding it. This is the main point. Sodium will remain in the extracellular space and thus expanding it. Because the plasma volume is only 25% of the interstitial fluid volume, only 25% of an infused crystalloid fluid will expand the plasma volume, while 75% of the infused volume will expand the interstitial fluid. So please remember, only 25% of infused crystalloid fluid will expand the plasma volume, and remaining 75% of the infused volume will expand the interstitial fluid. Thus, the predominant effect is only 25% of transfused crystalloid remains in the intravascular space and 75% diffuse into interstitial space. So this is the classification of crystalloids or types of crystalloids: hypotonic, isotonic, hypertonic, as we have discussed earlier. Hypotonic D5W, half NS, this is isotonic NS, normal saline, ringless lactate, plasma light, and hypertonic includes hypertonic saline, 10-25%, 50% dextrose. Again, ionic and non-ionic. Ionic includes NS, normal saline, dextrose saline, this is DNS, ringless lactate, and non-ionic is 5% dextrose and 25% dextrose. So, crystalloids contain sodium as a main osmotically active particle, useful for volume expansion, mainly interstitial space, for maintenance infusion, and correction of electrolytes abnormalities. Types of crystalloids: isotonic crystalloids have tonicity that is equal to the plasma in the body. The fluid will distribute evenly between the intravascular space and cells. Examples are lactates ringus or ringus lactate, 0.9% NaCl, that is called as normosol, normal saline, and only 25% remain intravascularly. What is hypertonic saline solution? Hypertonic crystalloids have tonicity higher than the body plasma, and the administration of hypertonic crystalloid causes water to shift from extravascular space into the bloodstream, increasing the intravascular volume. Examples of 3% NaCl, 0.9% normal saline with 5% dextrose, and 10% dextrose in water. What is hypotonic solution? Hypotonic crystalloids have a tonicity lower than the body plasma, shift from the intravascular space to the extravascular space and eventually into the tissue cell. Examples are D5W, dextrose 5% in water, 0.45% NaCl, 0.25% NaCl, less than 10% remain intravascularly, and inadequate for fluid resuscitation. So these are the types of crystalloids: isotonic crystalloids, hypertonic saline solutions, and hypotonic solutions. So this is hypotonic, this is isotonic, equally distributed, and this is hypertonic. Here H2O goes out, and in this hypotonic H2O goes in. You can see here in this slide, hypotonic shift from the intravascular space to extravascular space, and in this hypertonic, the administration of hypertonic crystallite causes water to shift from the extravascular space into the blood stream. You can see here by this illustration by Rickel Wallach. Commonly used fluids. Lactated ringers, that is called as LRs, is an isotonic crystallite that contains sodium chloride, potassium chloride, calcium chloride, and sodium lactate in sterile water. Normal saline solution, this is called as NS or NSS, is an isotonic crystallite that contains 0.9% sodium chloride salt in sterile water, and 5% dextrose in water, it is called as D5W, is packaged as an isotonic carbohydrate sugar solution that contains glucose sugar as a solute, which is used by the cells to create energy. So these are the three solutions, which are three fluids which are commonly used in various replacement therapies or maintenance therapies: lactated ringers, LR, NSS normal saline solutions, 5% dextrose in water, that is D5W. These are commonly used fluids. This is the comparison of plasma and crystallite resuscitation fluids. You can see here this plasma 0.9% NaCl normal saline, ringers injection, ringers lactate, normosol, and this is the osmolality, milliosmol per liter, and this is the milliequivalent concentration in milliequivalent per liter. This is lactate, and this is, you all know, bicarbonate buffer is present in plasma. Comparison of composition of various crystallite solutions. You can again see replacement. For the replacement, normosols, lactate ringers solution, lactated ringers, RL, plasma light, and normal saline. For the maintenance, you can also see normosol, plasma light, 5% dextrose in water, and this is 0.45% NaCl plus 2.5% dextrose. These are the buffers present in these solutions, and these are the concentration in milliequivalent per liter. So this is a summary of various fluids used in fluid therapy. Most physiological is RL, ringers lactate or lactated ringers solution, rich in sodium, NS, DNS in RL, rich in chloride, NS, DNS, isolite G, rich in potassium, iso MPG, correct acidosis, RL, all isolite except iso G is used for the treatment of acidosis or for the correction of acidosis. Isolite G and normal saline is used for the treatment of alkalosis. Glucose-free saline and RL, sodium-free dextrose solutions, potassium-free NS, DNS dextrose solution. Avoiding liver failures, RL and 5% dextrose and iso G. Avoiding renal failure, NS, RL and all isotypes. Provides phosphorus, this is isolite M. For the maintenance fluid or maintenance therapy, 5% dextrose, dextrose with 0.45% normal saline. And for the replacement therapy, normal saline, BNS, ringers lactate. And for specialized fluid, we can use 25% dextrose, sodium bicarbonate, potassium chloride. Next category is colloids, plasma expanders. The term colloid is derived from Greek word glue. These solutions are also called as suspensions or plasma expanders. Colloid fluid is a saline fluid with large solute molecules that do not readily pass from plasma to interstitial fluid. Colloids have high molecular weight, around greater than 30,000 Daltons, that largely remains in intravascular compartments. The retained molecules create an osmotic force called colloidal osmotic pressure or oncotic pressure. So what is oncotic pressure? Retained molecules create an osmotic force. This is called as colloidal osmotic pressure or oncotic pressure. In normal plasma, the plasma proteins are the major colloids present. So this is the classification of colloids: natural colloids, artificial or synthetic colloids. Fresh frozen plasma, albumin 5%, 20%, 25%, plasma proteins 4%, 5%. These are natural colloids. And artificial colloids, dextrins, gelatins, and HES. What is HES? Hydroxyethyl starch. Hydroxyethyl starch. What is HES? Hydroxyethyl starch. This is synthetic colloids or artificial colloids. So please write in the box, what is HES? Please write in the box, what is HES? What is HES? Please write in the box. What is HES? Hydroxyethyl starch. Okay. So this slide is showing characteristics of IV colloid fluid per 100 ml infusion. Fluid type: 5% albumin, 25%, 10% dextrin, 6% dextrin, starch, pentastarch. This is oncotic pressure, plasma volume expansion, and this is the duration of effect. So colloid fluid is about 3 times more effective in expanding the plasma volume than the crystalloid fluids. This is the important feature, that is colloid fluid is about 3 times more effective in expanding the plasma volume than the crystalloid fluid. So what is the difference between crystalloids and colloids? Crystalloids, aqueous solution of low molecular weight ions with or without glucose, and whereas colloids, high molecular weight substances similar to plasma proteins. These are plasma expanders. Crystalloids rapidly pass through semi-permeable membrane, extravascular space expanders, and these are do not across capillary membranes because they are high molecular weight compounds, intravascular space expanders. Intravascular, this is half to 20 to 30 minutes, and this is 2 to 8 hours. This reduces colloid oncotic pressure. This is used for maintaining colloid oncotic pressure. Poor capillary perfusion. Here capillary perfusion is good. Risk of overhydration, and it may cause tissue edema, crystalloids. And in the case of colloids, this is insignificant. This is the advantage of crystalloids. No anaphylaxis. It may occur in colloids, or cheaper, and these colloids are expensive. This is readily available. So these are the advantages and disadvantages of colloids and crystalloids. Advantages: smaller infused volume, prolonged increase in plasma volume, less cerebral edema in the case of colloids. And in the case of crystalloid, lower cost, greater unit flow, replaces interstitial fluids. And these are the disadvantages: greater cost, coagulopathy. In the case of colloids, pulmonary edema, decreased GFR. In the case of crystalloid, dynamic improvement, peripheral edema, and pulmonary edema. So volemic shock, isotonic saline or NS, normal saline is selected as initial fluid because 1 liter of NS will expand intravascular volume by 300 ml. Unknown glycemic status: if dextrose solution will rise glucose level rapidly. In the case of unknown renal status, RL can cause hyperkalemia or lactic acidosis. And this is reaction free, or compared to colloids, least expensive and readily. This NS, isotonic saline or crystalloid, normal saline. RL is preferred IV fluid after urine output is established. RL is most physiological fluid, as you all know, so large volume can be infused without electrolyte imbalance. Colloids in hypovolemic shock, more effective plasma expanders as these agents are restricted to intravascular compartment, lesser risk of pulmonary edema. Primary indication is hypotension in protein losing state, burns, and although used in shock, they offer little or no advantage over crystalloids. Blood in hypovolemic shock in patients who are bleeding, severe anemia, however, with blood transfusion, hematocrit should not raise over 35%. And this may increase in blood viscosity, which leads to stasis. So, in the case of hypovolemic shock, isotonic saline and normosaline is selected initially, and then we can use RL in the unknown renal status, and we can use dextrose solution in the case of unknown glycemic status. RL is preferred. IV fluid after urine output is established. Consideration during fluid therapy. Type of fluid, no ideal intravenous fluid solution, crystallite usually used. Rate of administration modified depending upon the patient and underlying disease process. It is important to define the amount of fluid to be given over a defined interval. In whom to do fluid challenge test. We should cautious about safety limits. Therefore, it is important to choose the fluid most appropriate to the patient's needs. So these are the considerations which should be taken during fluid therapy. Next topic is Gibbs-Donens membrane equilibrium. What is Gibbs-Donens membrane equilibrium? These are scientists. These are two scientists, Gibbs and Donens, and the hypothesis is Gibbs-Donens membrane equilibrium. So what is this Gibbs-Donens membrane equilibrium? When membrane is freely permeable to ions, sodium and chlorine, and if the concentration of ions on both the sides is different, the ions freely diffuse to attain equal concentration. Gibbs-Donen observed that the presence of non-diffusible ion or on one side of the membrane alters the diffusion of diffusible ions. The Gibbs-Donen effect describes the unequal distribution of diffusible ions on either side of semi-permeable membrane or between the compartment, which occurs in the presence of non-diffusible ions. So you have to remember that this Gibbs-Donen effect describes the unequal distribution of diffusible ion on either side of semi-permeable membrane, which occurs in the presence of non-diffusible ions. We can understand this hypothesis by the experiment. The compartment A contains a solution of sodium proteinate in which sodium exists as sodium ions, sodium cation, and protein as proteinate Pr minus, and sodium salt of protein is a colloidal solution, and the proteinate Pr minus is colloidal and is not diffusible through the membrane. So it is non-diffusible. The compartment B contains a solution of NaCl in which both sodium and chlorides are diffusible. So you can see here, this is an experiment by which we can understand this Donen effect. This compartment A, this is compartment A, this is B. Here you can see sodium proteinate, and you can see here sodium chloride. According to Donen effect, the non-diffusible ion or ions on one side of the membrane influence the diffusion of diffusible ion or both, and quality and quantity of diffusible ion will be influenced. In above situation, sodium ions can diffusible either way, but chloride ion can diffuse only to the left. So chloride ions can diffuse only to the left, and that is A compartment containing non-diffusible proteinate, whereas proteinate cannot diffuse at all. So you can see here sodium proteinate is not diffusible. It is non-diffusible in nature. So you can see here sodium ions can diffuse either way, but chloride can only diffuse to the left or towards A compartment, where proteinate or non-diffusible ions are present. After equilibrium is attained, the following will be the situation in both compartments. In the side A, there will be more sodium. You can see by this diagram, sodium 120, protein 8 90, chloride 90. You can see chloride can diffuse to A here, and this sodium 60 and chloride 60 in here, sodium 120, protein 8 90. Protein 8 does not diffuse, and this chloride diffuse to A compartment. So in the side A, there will be more sodium, as sodium ions have to balance now in addition to the existing non-diffusible protein 8. The newly entered chloride to maintain electrically neutrality. On the other hand, in side B, sodium has to balance only chloride, which are remaining after diffusion to A side. Hence, the concentration of sodium ion inside A will be greater than that of sodium inside B. You can see here, sodium A is greater than sodium B. So here you can see sodium A is greater than sodium B. Thus, total ionic concentration or total ionic concentration inside A will be much greater than inside B. You can see here, total concentration, total ionic concentration will be much greater or is greater than side B. The concentration of chloride ion in A should be much less than inside B. Means chloride A is less than chloride B. You can see here 30, here chloride is 60. On the other hand, chloride inside B, you can see here, will be greater than side A. So chloride B is greater than chloride A. At equilibrium, the product of diffusible ion or either side of membrane will be equal. So what is the summary of this Donan's effect? On the side in which non-diffusible ion is present, there is accumulation of oppositely charged diffusible ion sodium. In the other side of the membrane, the non-diffusible ion have made the accumulation of diffusible ion in the same. You can see here, this chloride and this is sodium. On the side in which non-diffusible ion present, so protein, there is accumulation of oppositely charged diffusible ion. You can see here, sodium, protein negative, sodium positive, accumulation of positively charged ion, and another is in the other side of membrane, the non-diffusible ions have made the accumulation of diffusible ion of the same. The total concentration of all the ions will be greater in which the non-diffusible protein is present, leading to osmotic imbalance between two sides. This is greater than the compartment B. When two solutions containing diffusible and non-diffusible ions are separated by semi-permeable membrane, diffusion takes place towards non-diffusible ion containing side. You can easily see by this experiment where non-diffusible ions are present. This chloride can diffuse to A. This also reduces the diffusion of likely charged ion to dead side. As a result, on the side which contain non-diffusible ions, diffusible counter ions are more concentrated, while the like charged diffusion ion concentrated more or opposite side. This is called as Gibbs-Donan effect. However, the total number of cations and anions are equal on both sides at equilibrium. You can see here. Total number of 120 cations and anions. Cation 60, anion 60. So what are the biological or biomedical importance of this Donan's equilibrium? Donan's equilibrium has the following effects in the body. First is difference in the ionic concentration of biological fluids or proteins in the plasma and ISF. This is interstitial fluid. The lymph and interstitial fluid have lower concentration of inorganic cations, sodium and potassium, and the higher concentration of anions, chloride, compared to plasma. Proteins have much higher concentration in the plasma than in interstitial fluid. This is due to impermeability of capillary wall to proteins. As per the Gibbs-Donan effect, non-diffusible ions like protein in plasma enhance the outward diffusions of anion like chloride from blood vessel. This reduces the efflux of diffusible cations like sodium Therefore, there is lower concentration of sodium and higher concentration of chloride in fluid in lymph and ISF as compared to plasma. What is ISF or tissue fluid? Is a solution that baths and surrounds the What is ISF or tissue fluid? Tissue fluid is a solution that baths or surrounds the cells of multicellular animals or interstitial spaces. Fluid present in interstitial spaces. It is the main component of extracellular fluid, uh, which also includes plasma and transcellular fluid. We have just studied. So you have to remember one thing: the lymph and interstitial fluid have lower concentration of inorganic cations and higher concentration of anions compared to plasma. Or we can say proteins have much higher concentration in the plasma than interstitial fluid. Second biomedical importance is about osmotic pressure. Due to this effect, sodium ions are held back in plasma and hence increase the osmotic pressure. Concentration of sodium and potassium ions in renal glomerular filtrate. It is observed that slightly higher chloride concentration and slightly lower concentration of sodium or potassium are found in renal glomerular filtrate than in the plasma. In case of dialysis, in renal failure, donor membrane equilibrium is the basic principle involved in the artificial means of purifying blood by dialysis in the patient of renal failure. So this is the most important biomedical importance. This is dialysis in renal failure. Resting potential of membrane due to chloride and sodium potassium concentration unevenly distributed. There is resting transmembrane potential, that is minus 90 MV millivolt. Then membrane hydrolysis. What is this membrane hydrolysis? The relative strength of hydrogen and OH minus ions, and therefore the acidic or alkaline nature on either side of membrane is influenced by the presence of non-diffusible ions. These are influenced by the presence of non-diffusible ions. This phenomena is referred as membrane hydrolysis. Donor membrane equilibrium explains the greater concentration of potassium ions in the case of in the gastric juice. Concentration of erythrocyte chlorides due to the Gibbs-Donen effect. It is observed that chloride concentration in erythrocytes is only 1/4 of the plasma concentration. It causes lowering of pH of RBC. So pH of RBC due to retention of hydrogen or hydrogen as a result of Gibbs-Donen effect. pH of RBC is slightly lower. That of plasma, hemoglobin of RBC is negatively charged, and this causes accumulation of positively charged ion, including H+. Therefore, the pH of RBC is slightly lower, around 7.25, than that of plasma. So, by the effect of Donen's, pH of RBC is or may be lowered. Next is chloride shift or hamburger phenomena. It is due to Gibbs-Donen equilibrium. You all know chloride shift. And lastly, electrical charges due to plasma protein and ions. The potential inside the vessel relative to its outside makes plasma slightly electronegative. So these are the uses of Donen's equilibrium, like dialysis in renal failure. The basic principle is Donen equilibrium or Donen's membrane equilibrium, which is used in this dialysis. Membrane hydrolysis, differences in ionic concentration of biological fluids, osmotic pressure, pH of RBC, chloride shift, hamburger phenomena, that is also called as chloride shift, and electrical charges. So please add in the box, what are the important biomedical uses or importance of this Donen's equilibrium? Name any two. Name any two. Please write in the box the two biomedical importance, biomedical uses of this Donen equilibrium, please write in the box. Yes, am I audible to all of you? Please write in the box what are the uses or what are the biomedical importance. Yes, first is in dialysis, difference in the ionic concentration of biological fluid, chloride shift, membrane hydrolysis, lowers pH of RBC, electrical charge. Yes. So important point is this is an experiment. You can see here sodium proteinate. This proteinate is non-diffusible. This sodium and chloride, these are diffusible ions. And after equilibrium is attained, the following will be situation in both compartments. You can see here 120 sodium, this chloride shifts to or can diffuse to compartment A, and here it will 30. So total cation anion ions are equal 120 120 60 60, but you can see total concentration of all the ions will be greater in which the non-diffusible protein net is present, leading to osmotic imbalance. Total ions are greater than B in the compartment A. You can see here. Have you understood this Donan equilibrium? Please write in the box by this experiment. Have you understood? Have you understood this whole hypothesis or phenomena of Gibbs Donan equilibrium? Please write in the box. And their biological or biomedical uses. Please write in the box. Am I audible to all of you? This Donan equilibrium is important for your examination purpose. So I will repeat this whole presentation. Yes, today's topic is biochemical basis of fluid therapy and Donan's membrane equilibrium. You can see here intracellular fluid and extracellular fluids. Intracellular 2/3 of the total body fluid, extracellular 1/3. Extracellular fluids fluid is divided into three spaces or three compartments, subcompartments, interstitial, intravascular, or transcellular. So interstitial contains 3/4 of all the fluids in extracellular space. Total blood volume is roughly 8% of the body weight and plasma roughly 5% of the body weight. You can see here by this diagram, this is around 65 to 66%. This is 35 to 36%. Plasma 8%, interstitial fluid 25%, and this transcellular fluid around 2%. Principal component of extracellular fluid is sodium, and principal component of intracellular fluid is potassium. Three types of fluid therapy: replacement therapy, this adjunctive therapy or fluid resuscitation, and supportive therapy. Maintenance to supply daily needs, replacement to replace deficit and ongoing losses, and resuscitation to correct an IV or extracellular deficit. These are the indications for rapid restoration of fluid and electrolytes in dehydration due to vomiting, diarrhea, shock due to hemorrhages, sepsis, burns after surgical procedures, anaphylaxis, cardiac arrest, hypoxia post gastrointestinal surgeries, and various acid-base abnormalities and electrolyte abnormalities. These are the advantages of this fluid therapy: life-sustaining fluids, therapeutic effects, allows fluid intake when a patient has GI malabsorption, and these are the disadvantages. Needs hospitalization. They may cause infection, pyrogenic reaction, discomfort, and it may lead to fluid overload, or there may be chances of fluid overload. What is dehydration? Dehydration, or the loss of fluid from the interstitial space in the form of increased fluid loss from vomiting, diarrhea, and polyuria. You can see here capillary refill time 2 to 3 seconds in mild cases and greater than 3 seconds in severe cases. Weight loss, PCT increased, albumin or total protein increased, BUN and creatinine high, and there may be pre-renal azotemia. You can see here 5% non-clinically, 5 to 6% loss of skin elasticity. These are the degree of dehydration. Please remember this 4% or above 4%, 5 to 6%, this loss of skin elasticity. Types of fluid: crystallites, isotonic, hypotonic, hypertonic, and colloids are plasma expanders. Crystallites, you can see hypotonic, isotonic, hypertonic. These are the examples of this: normal saline, isotonic normal saline, ringus lactate, then hypertonic, then ionic is normal saline, dextrose saline, ringus lactate, and non-ionic is 5% dextrose and 25% dextrose. Commonly used: LR, lactated ringus, normal saline solution, 0.9% sodium chloride salt. Dextrose in 5% dextrose in water. Most physiological is RL. Glucose free is ringus lactate and saline. Colloidal, that is called as plasma expanders or suspensions. You can see here natural and synthetic. Fresh frozen plasma, albumin, plasma proteins, here dextrin, gelatin, HES, hydroxyethyl starch. These are the advantages and disadvantages. Crystallites are cheaper, greater urinary flow, replaces interstitial fluid, and disadvantages are transient hypodynamic improvement, peripheral edema, and in the case of colloids, advantage is small infused volume, prolonged increase in plasma volume. Disadvantages are greater cost and coagulopathy. Consideration of during fluid therapy, we should take care of this rate of administration, type of fluid, in whom to do fluid challenge test, safety limits. Therefore, it is important to choose the fluid most appropriate to the patient's needs. What is Gibbs-Donan membrane equilibrium? The Gibbs-Donan effect describes the unequal distribution of diffusible ions on either side of a semi-permeable membrane or between the compartment, which occurs in the presence of non-diffusible ions. You can see by this experiment, this is sodium proteinate, non-diffusible, and the sodium chloride on the other side. After equilibrium is attained, the following will be situation in the both compartment. You can see here 120 sodium, 90 proteinate, 30 chloride ions can diffuse to compartment A. So here total ion concentration is more than B in A compartment, but equal cation and anion in both the compartments, 120, 120, 60, 60. So these are the biomedical importance of Donan's equilibrium: differences in the ionic concentration of biological fluids, osmotic pressure, dialysis in renal failure, resting potential of membrane, membrane hydrolysis, concentration of erythrocyte chlorides, lower pH of RBC, chloride shift or Hamburger phenomena, and electrical charges. So now, have you understood this whole topic, fluid therapy and Donan's equilibrium? Please write in the box. Have you understood? Am I audible to all of you? Please write in the box. Am I audible to all of you? Okay. So, thank you. Thank you once again.